So with PMD, one of the most prevalent orthopedic manifestations is scoliosis. And I saw Nicholas for scoliosis, and I have a case coming up with PMD with scoliosis. So scoliosis is obviously in my wheelhouse. I'm a pediatric ortho surgeon, but more subspecialized in spine surgery. Almost 90% of PMD patients develop scoliosis. So you will at some point need an orthopedic surgeon. They can hear me. Hello. So 90% of patients with PMD develop scoliosis. And so at some point you will need an orthopedic surgeon. It's almost inevitable. The scoliosis I think of as Dr. Christensen was explaining, you have muscle imbalance. And so if you have lower tone in your upper extremities, higher tone in your lower extremities, the trunk is somewhere in the middle. And so it's muscle imbalance. It's low, it's high, it's normal, it's just imbalance. So it's going to cause asymmetry to your spine. As that asymmetry persists, you develop a scoliosis or a curvature of the bony column. The issues surrounding that result in sitting imbalance. So many patients can develop just frank pain. So it might not be obvious at first, but you'll notice that you have to keep repositioning your child after, instead of 8 hours, then all of a sudden it's 6 hours, then 4 hours, then every 2 hours, just constant repositioning. Wheelchair adjustments are more difficult, used to be easier. Then a couple years later, it's getting a little harder. You have the same wheelchair specialist, and it's just getting to be more difficult. So it's not obvious, it's more of a subtle finding when it comes to pain, because most patients have a high tolerance for pain, so they're not going to say necessarily that they have pain. It's just a repositioning or fatiguing. And then we talked about this earlier, pulmonary issues related to the scoliosis, and feeding issues, because our trunk is actually one of the largest muscles in the body. So, and our organ systems are in the same area, our lungs are obviously in the same area, but more than that, the work of sitting takes a lot of energy. It really does, and we take it for granted because we think about, we walk or we move our hands, but sitting is probably consuming a lot of our ATP or our energy, our calorie requirements. So if we're expending so much energy in the work of sitting, we can't put that work to breathing, and we can't put that work to eating. So after we correct scoliosis, sometimes we find that other parameters, including lung function and feeding, improve substantially. So it's more than just, it's an entire quality of life improvement, which is the only reason we would actually subject a vulnerable child to the kinds of surgeries that we do. So generally with PMD, progression is certain. That is not the case necessarily with CP and other disorders. It tends to progress as the muscle imbalance issues progress, as the myelin issues progress. So it's just the end of a series of more biochemical molecular trends. Early on, we generally recommend TLSO bracing, and there are separate reasons for that. One is you can't fuse a young child. You just can't for lung development and many other issues, growth and other complications. When TLSO fails, then we do have other regimens such as growing rods. So if any of you meet an orthopedic surgeon, they're going to start suggesting growing rods. The thing about growing rods is not a perfect surgery. It does have a significantly higher rate of complications. However, if it's necessary, we start to consider it. So if it's progressing, if the curvature is progressing to the point where those quality of life issues I mentioned are also deeply affected, then we would suggest growing rods or some other growth-friendly intervention. Those generally we consider if the child is less than 8, because the lungs continue to develop up until age 8. So we really don't want to fuse a thorax before age 8. And those complications are manageable. It's just once you start that road, you're on that road. You can't undo a growing rod. So it does mean you have to have a special relationship with your orthopedic spine surgeon, You have to know it's going to be a hard road, but it's a road that you go through together. So it's taxing for the surgeon and for the family. It should be done, I think, at a spine center that does growing rods frequently, or growth-friendly intervention. You know, Riley's obviously one of those places. We're all involved in a national growing spine study group, and we talk about all these issues all the time, and we learn from each other across the nation. When you get to that point, and ideally where the curve has progressed but the child is old enough, then that's when we talk about fusion. So fusion is basically, we will, as much as possible, straighten the spine and then hold it there. So the muscle can't move it. You know, so any progression in terms of muscle tone becomes irrelevant, because now we're going to stop that progression just almost by brute force, mechanically. I mean, orthopedists are not the smart ones in this room. We're the construction workers, and so we're going to stop it, and the muscles can do whatever they want, but our constructs can be stronger. Now that is why the truncal balance, now the child can put his energy into the legs, the arms, the breathing, the feeding. We've put in rods and screws, and they don't have to put any energy into their truncal muscle at this point. So it's interesting. Now this is where diagnosis becomes important. So when it comes to cerebral palsy, we generally don't think of fusing until a curvature is 50 to 60 to 65 degrees. Now with some of the more, the different diagnoses, and on one spectrum you have muscular dystrophy, where we start fusing at 20 degrees, because we know that's going to rapidly progress. And the same thing with some of the muscle disorders, and with PMD, there's not a lot of research orthopedically with PMD, but their thought is do it earlier. Don't wait, there's no reason to wait to 50 degrees if the child is age appropriate. There's no reason to wait to 65 degrees, 75 degrees, because it's going to get there. It's going to get there, so start earlier, and then you have a lower rate of complications, and I will talk about the complications, because I think it's a hard decision for families to make. But if you can reduce your risk of complications by fusing earlier, then it's a less bumpy road. So it's important to understand the complications. So obviously, this is, and I think this is an example I showed Nicholas's family yesterday. This is what we do essentially. So we take a spine as much as possible, we straighten it, and we put in screws and rods. It's a big surgery. It's not, and I'll talk about the smaller surgeries, but it's not a hamstring release, it's not an adductor release, it's not even a hip surgery. It's a big, big, big surgery. And then, so now these screws and rods are going to hold it. The muscle tone, it's irrelevant at that point, essentially. So one might ask, is there, I mean, there is a risk of neurologic injury, and in the case of PMD, and Dr. Christensen alluded to it earlier, some of that neurologic injury can result in autonomic dysfunction, because those nerves are run along the same chain next to the spinal cord. So it may, so an unknowing spine surgeon may not understand that with PMD, and understand that blood pressure fluctuations can be a huge issue. And so we see them in the OR, so I think it's very important as we're correcting. We also have a set of anesthesiologists who are familiar with PMD. They don't have to be the world's expert in PMD, but they have to understand that we're going to see blood pressure fluctuations. Those are that's caused by, most of the time, us. Oftentimes an anesthesiologist thinks it's them. But sometimes it's as we're correcting the spine, we're stretching the sympathetic chain, and we're doing it. So if they don't let me know and they think it's them and they're trying to fix it, then I don't know I'm causing it. And so I need them to let me know so that I can stop doing that. Does that make sense? So you don't need the world's expert in anesthesia, but you need someone who at least, like Dr. Christensen was mentioning earlier, that at least wants to learn about PMD before they do the case. Because it's all in the literature. It's there. So that is the type of neurologic injury that may become relevant post-operatively. if you have to start managing blood pressure and sympathetic issues post-operatively, that's another burden that you may have to face. Other things are we still monitor their nerves, their motor nerves, because if they're doing relatively well from a lower extremity standpoint in terms of contractures, then we don't want to make it worse by altering their motor nerves. So I monitor everything. I monitor motor, I monitor bowel and bladder function. I monitor everything when I'm doing these cases, because it's whether or not they're ambulatory, it still matters to me that they come out the same way they came in, except straighter, ideally. So because those functions are important regardless of whether you're walking or not. So, and infection is a big deal. The rate of infection with any neuromuscular disease for spinal wound is 1 in 10. So that's nationally, there's different, it can vary from 5% to 30%, but generally I say 10%. So 1 in 10. Infection is where I've worked with Dr. Moody. I had a spinal wound infection in a patient who, just the worst case scenario, these kids are already in the ICU, they're sick, and then we add another event to their postoperative course when it's a big surgery and you add an infection to it. So I really emphasize that to parents, because we can fix it, but it's a bumpy road, and it's a high rate. And so 1 in 10 patients do get infected. So it's going to be important, again, to have access and a relationship with your surgeon, because a spinal wound infection doesn't occur the day of. It usually occurs 2 weeks later, 1 month later, 6 weeks later. So again, it's important, I think, to go to a pediatric spine surgeon who does difficult cases, because they have generally protocols for infection. They follow their patients longer term. I assume, they care and they want to help. So it's a relationship that's doesn't end the day of surgery. It keeps going through potential complications. I usually tell families, it's not whether or not you like the surgeon the day of surgery, it's like, are they going to be there for you after? If everything goes 100% correct and everything goes great, it doesn't matter who your surgeon really is, as long as they can do the surgery. It matters how much you like the surgeon, because they have to be there for you through the complications.
How easy is it for, in our situation, we're going to go out of town. How easy is it for our local orthopedic surgeon to communicate certain things, those kinds of things?
Communication is everything. Is it easy? No. Those, I recommended Texas Gush to you. Those of us who are in that, community of complex surgeons, what we recognize about spinal wound infection, it presents in different ways. There's so much nuance to it that what seems benign, and I usually find that the local orthopedist thinks it's nothing. And then, because it's not rip-roaring, but the sooner I can get to it, the better I can fix it. So I'm hyper-vigilant about infection and hyper-aggressive about infection, because earlier management is better than delaying and letting it simmer. So it is hard. I think a local orthopedist could manage the immediate, but within that week, get to your treating orthopedic surgeon. So I guess that's how I would. What we learn about doing more and more complex surgeries and more infection is that it shows up in different ways, especially in PMD and other situations where they can't express what's going on in their back. Because pain is anticipated after spinal surgery, but it's a different kind of pain, and kids who can express the onset of infection tell us it's different. So I was getting better, and then I got worse, and it's right there, it's right here. It's not, my whole back hurts. So we use a lot of implants nowadays. Using those implants, using those screws offers better correction and offers better rigidity. So oftentimes after surgery you don't require a brace, but with that there's more implants, there's more hardware, and there's a chance of breakage. We're putting a lot of stress on the screws. That's more of a technical concern. Again, those of us who do a lot of spine surgery, we do things to mitigate implant-related issues, but that's always a potential. Dural tears. So oftentimes, and this is a kind of a bigger issue because if you have a baclofen pump or other things, so it's important to know, and at least your community to know, or have a relationship with the neurosurgeons who do the baclofen pumps. So if you're going to have a fusion, then you can't get a baclofen pump easily after a fusion because they can't access the spine for the catheter. So on the other hand, if you do the baclofen pump first to help with tone, then we have to know the surgeon who put it in, because sometimes they had to get it out of our way for me to do my job. And sometimes that's that communication, if that breaks down, you're kind of in a bind at the, with the baclofen pump.
What is that?
Yeah, the baclofen pump is like a little, it sits in your abdomen, it's inside. It's a way of delivering baclofen right to the spine, as opposed to taking it in a pill. But it has to go through the spine to get there. All right, so as many persons use a baclofen pump to avoid tone issues, and those tone issues, or to decrease the tone issues. But those tone issues, if they ultimately end up progressing to scoliosis, then sometimes you need surgery, and then that baclofen pump becomes an issue. It's just something to be aware of. As most families are in different communities than ours, where we know each other, we know these issues. But as we mentioned earlier, you may be educating your surgeon. I'm going to try to not use up too much time. Now, so that fusion, you're stiff in that spine, but in some ways it's not a bad thing. In this case, it's a good thing. It's letting your muscle tone not have to deal with the spine, the trunk. It's a huge, huge, huge muscle. So it's really in an effort to put that energy into the other parts of the body and other functions of the body. So stiffness, I know some families who worry about that, but even many studies show that care providing and transfers are easier, and I liken it to, like, imagine lifting the same weight of 2x4s, but having them be like floppy rubber, but the same weight. It actually is easier to carry those 2x4s and transfer, and it's less painful for the patient. So there's a lot of quality of life issues and transfers even that help the caregiver and the patient by the fusion. And it seems counterintuitive, but it seems to be the case. Wound issues and pain. Okay, so bleeding, obviously, lung issues. So post-operatively, general anesthesia. This is 10 hours of general anesthesia. You need to be at a center that has a great pulmonary team, okay? Because that general anesthesia is going to really just affect your lung function in the early postoperative period. So I recommend ICU facilities. I recommend a facility that has a pulmonary team and a good neurology team, because the neurologists help a lot postoperatively with pain, tone, and the medicines, and understanding and educating the others in the environment about PMD. So it's hard to do these kind of surgeries in a community hospital. It would be hard, I think. So again, anesthesia, medications, pressure sores, blindness is interesting. So blindness, it can be more relevant, I would say, for the older PMD patients. So we still don't know what causes intraoperative blindness. We do know it's from prone positioning. So from lying down like this while the surgeon's operating on your back. In general, we don't see that in younger age children, so they think it's a vascular event. So again, so the older you are, the less compliant your vessels are. However, there is a possibility that it's an autonomic event too when it comes to vascular constriction and dilation. So there is that possibility all the time, and it's just something to be aware of. Most anesthesiologists definitely talk about that prior to surgery, but as you were asking about, whether your child can see, I mean, that is a function that they rely on, and so it's important to know what potential complications can occur.
Is that blindness reversible after surgery? Or?
Sometimes, not all the time. And then obviously these are big surgeries, and they're not a walk in the park. They're huge surgeries, and there's always a risk of death. And any surgeon who doesn't mention that is not doing their job. So, any questions about spine?
I have a question. My son is only seen like once a year, and I was wondering if that is like way out and saying like he should be seen like every 6 months or something. Right?
Well, I mean, it depends on how interdisciplinary your environment is. I mean, I have neurologists, I have rehab doctors, they get seen by many people, so I usually only see once a year.
Okay.
But that's not to say that our rehab doctors and our pediatricians see them, and if something's changing, they will send them. So they're not being seen once a year in general.
Well, right, but by the osteo.
Yes. Yeah.
That's normal.
Yeah.
Okay.
And because I do know that my neurologists, my other doctors, if something's different, they'll send them to me. Uh-huh. Yes. Yeah. Yeah.
Now, there's preventive stuff for that, right? Like the little shorts that are connected, talking about the stitched in. I know everybody here knows what I'm talking about, right? To keep them
For spine?
right, instead of for their hips.
Just for hips. So I can start talking about hips.
Oh, okay.
So hip subluxation or hip dislocation is common. So it's very common with PMD. It's the right hip most of the time, which I don't understand why. Does anyone smarter than me know? I have no idea why it's the right hip more commonly.
Does the curve go the same way?
Well, that's a good question. What came first, the chicken or the egg? Did the right hip subluxation lift up the right pelvis so the curves always generally tend to go to the left? Or is it because the curve goes to the left of the right hip?
Would it be? Would it be because it's more dominant on the right side, like a right-handed person?
No idea. I have no idea, but it's usually the right side. I don't know why. So it tends to be the right side. It can be both sides. And then it can even dislocate. So this is where tracking or where follow-up is important because it doesn't dislocate overnight. It doesn't. It slowly ekes out. And so tracking is important. So you were mentioning, should I be seen? Yes, we should track hips and spine. Definitely, because we know these are common events. And so you have to monitor, and there's this thing called a migration index that we use as a surrogate marker. It's from the CP world, but without having enough research, is what we use in all our muscle disorders and neuromuscular syndromes. So as the hip starts to eke out, you don't want it to get all the way out. You want to put it back in, before it gets all the way out. It just decreases the complexity of the surgery. And so we put it in by a procedure called a VDRO. Now, it's important to realize that this procedure may need to be repeated during growing years because you put it back in, and then it's going to eke back out because we haven't changed the brain. We haven't changed what the muscles are doing. We haven't changed any of that. We're just construction workers that say, oh, it's coming out, let's put it back in. But the brain is still pulling the musculature out. And so it may have to be repeated. So I do a lot of timing because I don't want to repeat it every year. So I watch it, and if it gets to that point where like, oh my gosh, by next year I think it's going to come out completely, I better put it in now and hope to get a few years out of that. And then as they stop growing, it becomes more static. So then you don't have to, so you don't have to have repeated surgeries into adulthood. This is just during the growing years. So this is an example of a hip that's, sort of in, and now it's starting to come out, and then they did the surgery. So, but it wasn't all the way out yet. All right, so it's kind of sort of in. And so this degree of migration is what we measure. And we also track it, because some people, everyone's different.
How often do you recommend checks?
I do a year.
1 year?
I do a year.
How helpful is increasing weight bearing to keeping the hips in position?
Increasing weight bearing has an indirect effect because weight bearing requires a balancing of muscles. So it's helping them to use their muscles to stand. So it'll be indirect because it's all about muscle balance.
Doesn't that increase the muscle structure around the hip more?
But in a more balanced fashion. So the muscles are working. They're just not working in the right direction. They're not balanced.
So is it good to put it on a stander or not?
It is. And standing also has a second benefit of keeping your bones strong. And that's a huge benefit.
How much time do you recommend?
I don't have particular requirements, as much as one can.
They'll tell you, the kid will tell you when they're ready to
Yeah,
get out.
pretty much. Pretty much.
What's the difference between subluxation and dislocation?
Subluxation is the eking out. Dislocation is out.
I think some of the families have found that as the kids get older, the standing seems to create additional problems. The kind of fainting type things that we kind of tend to think about as being spells. So I guess my question would be, because they don't have the normal tone and they really don't stand,
Right.
they're standers, where's the happy balance? Is there one?
I don't know. I don't know what the happy balance is. We don't. It gets to a point where it becomes counterproductive, and I think that's going to be very individualized because I don't want too many spells by any means. And then that's where we come into play, to be honest. When
Positioning, and that helps some with the dislocation of the hips?
not in the longer term. But stretching and maintaining muscle balance.
Just another quick question associated with like subluxation and things like that. We just had some tendon surgery done on our son for his hips
Right.
and
Mhm.
for the Achilles and things like that. And I've noticed recently that he tends to have, at least on the surface, his feet and his legs seem to be a little colder. So do you generally see any type of circulation issues?
That's probably from the autonomic issues.
Okay. Okay. Any way to combat that? Or?
That would be a better question for neurology.
Okay.
What?
Not really.
Okay.
Yeah.
Socks and clothes.
Hydrated.
Okay.
Yeah. And then so the tendon surgery. So
Yeah.
here, general anesthesia, it's important to reduce the number of times they undergo general anesthesia. So in this case, here, one side is clearly more out than the other, but the other one's gonna get there. So I'm gonna put this kid under one general anesthesia and do both sides. Right, and so, because I don't wanna do the right side, and then 6 months later do the left side, and then, that's just more general anesthesia. So those are kind of decisions that a pediatric orthopedist who understands the risk of general anesthesia when it comes to PMD might consider.
My question, I've kind of decided for my child
Mhm.
to push off doing surgeries, just that's where we're at. So,
Mhm.
my question is though, I've noticed with him, like you spoke on the right hip side, both hips are out, and the right's obviously worse than the other, but, I
They're
think-
both completely out?
Yeah.
Okay.
Yeah, and actually he has like the leg length discrepancy, which is causing the scoliosis, which is not like an S curvature, it's more of like a turning, like if you look at his back, one side's in more than the other.
Well, all scoliosis is a turn.
Okay, it's a twist.
Yes.
Okay, got it.
Yeah.
I'm thinking thinking more of like, because when I look at it,
Yeah.
I don't see the S curvature, I just see it more, you know.
As a spin.
Yes,
Mhm.
which I, obviously, from the hips, I think that's where it started, because we didn't see it until the hips
Mhm.
to do that. So my question is though, for the hip stuff, if he went in to have that corrected for his spine, would he need to have his hips
That's a-
corrected at the same time?
So that's a lot of surgery. I wouldn't do it all the same day, but you don't know if the hips actually came first, because if the hips started to go out, then the muscle tone reached a point, muscle balance reached a point that might have also concurrently started affecting the spine. You know, it just got severe enough that both events occurred at the same time. I wouldn't do it at the same time, but what's interesting is if they've been out for a long time, putting them back in may hurt more
Exactly.
and cause more problems than just leaving it alone.
And that's where I'm at with it. But
Right.
I didn't know if it was counterproductive to.
It may be because they've already developed arthritis in their cartilage. So putting an arthritic hip back into the joint is more painful than just leaving it where it's at. And so hip surgery is a pain issue surgery at this point. It's not a walking surgery. You're not going to make the kid walk. The hips wouldn't have come out this far if they were walking. So you're not gonna, it's a pain, quality of life issue. Spine surgery has the other effects though with feeding and pulmonary. So spine surgery, you know, if it's severe enough, I would do that. Now the caveat to that is you're changing the position of the pelvis after the spine surgery. You may, if it's a painless dislocated hip, you may create a painful dislocated hip because you've changed the pressure on the femoral head, the arthritic portion of it. In that case, you may have to do a femoral head resection. Just get that cartilage out of there. That's what's hurting.
Well, as they grow, obviously you have to change the size of the hardware, right? So how's that going to work?
Yeah, you take out the hardware you can
You just go into another
Yeah,
surgery.
yeah.
Okay.
Exactly.
That's all.
Okay. Great. Okay, so now moving down the body, spine, hips, so ankles. So basically, ankle equinus is when you're walking on your toes. So it's a tight Achilles tendon. So this can initially make it very difficult to walk, and then later, if one is not walking, it makes it very difficult, even in the wheelchair, because that foot gets caught underneath the leg rest. I mean, and then you have to constantly, move it. Foot gets caught again 2 minutes later, you have to move it. So this isn't a procedure that we do just reserved for walking PMD patients. This is for anything that helps comfort and in the sitting position as well. So ideally, this is where Botox is probably initially used because it's a single muscle unit. So you can do a selective Botox injection, help to get it, and stretching and bracing, and when that fails, that's when we lengthen the heel cord. So then we lengthen the Achilles tendon that allows their foot to come up, and then it heals in that position. So it's not this floppy foot, it will heal in that position. And then over time, if they're young, they may develop again, and you may need to do it again.
What about a TENS unit? What about a TENS unit?
So that's to stimulate the muscle.
So that's a bad idea.
No, it's not a bad idea. It's just, again, muscle balance. It may not prevent this from happening, but if they're stimulating the counter muscles, it's not a bad idea. It's not a bad idea. So because for every muscle, every function in one direction, we have another muscle in our body that's not working as effectively to take it in the other direction. So if the foot down muscle is stronger than the foot up muscle, that's imbalance. And then you were mentioning the hip surgeries, the adductors. So the adductors are the muscles inside, on the inside, right here. So they're causing the scissoring. All right. So this is the typical, you're scissoring, the muscles are being in. It's also pulling the hip out. So earlier, before that hip starts to subluxate, you feel the tightness in the adductors. You've tried Botox, you've tried stretching, it's still getting tight, they're scissoring a lot. You will lengthen the adductor tendons. That will also probably increase your interval to having hip subluxation or hip dislocation. So yes, these smaller procedures, you know, are good early to prevent the bigger procedures later. And then it may need to be repeated. And it is general anesthesia, but it's a relatively short period of time of general anesthesia and a much simpler recovery than doing bony work. So these soft tissue procedures are a lot less invasive than bony work. And then you have the crouching too from the hamstring tightness. And then you have your heel cord, so it's very, and oftentimes they do these all at the same time. We'll do all the soft tissue procedures at the same time. And it's a relatively quick surgery.
Yeah.
So where do they feel the subluxation pain when they have subluxation?
In the groin.
In the
So diaper changes, you'll notice, like, are more difficult, and they're expressing pain. It's in the groin, and even sitting, you know, they'll have groin pain.
So it's up front. It's
It's not usually in the back. It's groin.
Wow.
What, like we did that surgery and they gave us a wedge for sleeping.
Mm-hmm.
I was wondering, like, before that, he would sleep all curled up, and I'm like, would like positioning at night with wedges or straps or something help prevent some of these things?
I don't think it would prevent. It may delay.
Yeah.
And the reason we give wedges at night after surgery is because you're still waiting for it to heal. So if you do the surgery and they sleep the first night all contracted again, it's going to heal in the short position. We want it to heal in the longer position. And then we actually stop the wedges after a while because now it's healed in a longer position. So it may delay, but not necessarily prevent.
Okay. Yeah.
Because they'll overpower the wedge.
Because I was thinking, gosh, he sleeps all curled up like that. How are we going to
Yeah.
combat 12 hours of staying, you know, curled
Right.
up?
Well, they generally will overpower the wedge.
Yeah.
You know, and also, you know, in many ways, if we want them to sleep comfortably too. So it gets to that point, if the wedge is influencing their sleep patterns, then it's a cost benefit. I think that's about all I had. Oh, so again, I mean, I know I talk a lot about surgical surgeons, and I think the more informed families are about the post-operative issues, it empowers you to dictate the post-operative course, but more importantly, it also just provides better communication between your surgeons, because at some point you'll probably meet an orthopedic surgeon, and it's important to know that they know all this. Cognition is one of those, like, we understand that the PMD patients are understanding the conversation, so you don't want a surgeon who comes in and starts saying, there's a risk of death, there's a risk of, all these things, without acknowledging that the patient's right there, and little, things like that, because these are hard discussions. If I know they're listening, and then I'll still have to say the same things, but it's at least acknowledging that they're listening too. So.
Question. I came a little bit late talking about the spine. When you x-ray, do you just x-ray when you're laying down?
I like sitting x-rays because the whole procedure is to improve sitting balance as well. So if I don't know what they look like sitting, and it's going to look worse sitting than lying down. So I like sitting x-rays.
How do you do the sitting x-rays for these children who don't sit?
Strap.
Do you x-ray them in their chair, which is
We can't x-ray through a wheelchair, so I mean, we do have, if they can't sit in long enough for us to shoot the x-ray, then we have to get lying down once. But there are x-ray technologists, at some of these, like Riley, they're really good at getting sitting x-rays. I mean, they're pretty good at it. And I used to be at Children's Hospital of Los Angeles. They're good at it too. So most freestanding children's hospitals have really good x-ray beds. Questions?
Another question. The hips. When my son had his, we also done the ligaments, the adductors, the hamstrings, the Achilles tendon.
Mm-hmm.
And I noticed the surgeon recommended it, and I was glad we done it all at once, because I really noticed a difference now.
Mhm.
Stretching a lot, so he's tight, but he's not.
Right. No, I think it's a great procedure. I think it is relatively benign, and doing it all at the same time is nice.
And then, chronic physical therapy,
Mhm.
I felt after finishing that,
Absolutely. I like aquatic because it's resistance. It's resistance training without the impact. Unfortunately, most insurance companies don't cover aquatic therapy, so it's very hard sometimes for families to get aquatic.
We got a hot tub,
Yeah.
and he does great.
Yeah. Yeah.
He does great.
All right.
Tuan was also talking to me about Botox. Can you talk a little bit more about that? Because we've never done Botox with Nicholas. Because I've heard too many parents tell me that it wears off fairly quickly, and then it has to get redone, and then
It does.
and then it also wears off more quickly with
Time.
with each additional one.
Mhm.
And then it's like the kids kind of, maybe everybody does it, but like they build an immunity to Botox.
Mhm.
Is that your finding as well?
Yes. I mean, it's short of surgery, so and it's good for single, localized. As Dr. Christensen was mentioning, in the mixed tone disorders, a pill will affect everything.
Right. That's
Right, so Botox is very useful when you want localized, you want to work on specific muscle without the generalized systemic effects of the pill. It has its value. That value starts to kind of wear off with repeated injections, which is when at least at Riley, I use the PM&R, the physiatrist to do the Botox injections. I know that they've exhausted the Botox when they start saying, okay, Dr. Myung, I think they're going to need, surgery. But it's avoiding surgery if you can, and I think you should try to avoid surgery to to one's comfort level and a reasonable extent, because surgery is a big deal, and they undergo general anesthesia, and they could have substantial complications after surgery. So.
Well, sometimes you walk out of there in worse shape when you get it.
Sometimes you can, absolutely. So, you don't want a surgeon who's trigger cut happy, when working with PMD. You don't. If you don't even know the person and they're like, we're going to do this and that, and I don't know. That's just my personal opinion.
So where is the point that you have surgery? Because at one point here you said when you start.
It is
getting
generally
that curve-
considered, we're thinking, with scoliosis, the literature is very limited on this. And it's actually limited on a lot of disorders. It really is. A curvature of 100 degrees is not going to do well postoperatively. That's a lot of surgery. I had to do a lot of work, and that muscle is curved 100 degrees. I often have to get plastic surgery involved. There's going to be a lot more bleeding, longer surgery, more infection risk, not as good correction, more pain afterwards. I don't want it to become that.
So,
but with certain disorders, if you know it's going to get there, don't let it get there, too. So it's a balance.
So
And
is
we think that
there
balance is
a
at 35
degrees of
degrees.
curvature where you would recommend starting, okay, now we need to start thinking about surgery?
Sorry, what curvature?
Degrees.
Well, in the literature, and this is limited literature, they said about 35. It's very limited, though. I mean, it's like
And that
very
would
small
necessarily
ends.
be for PMD.
No, that was for PMD.
Oh, it was for
Yes.
PMD, okay.
That was specifically for PMD.
Okay.
In CP, our cut, it's about 50. We start having the surgery, and in muscular dystrophy, like Duchenne's, it's around 20, 25 degrees because of the pulmonary demise is so rapid.
So is that in a paper that's about, not just specifically about PMD?
No, it was specifically about
Pediatric?
PMD.
It was?
Yes.
Okay.
I have to
that one on.
No, it was, but again, that's one person's study, one person's experience, and I think the N was like 9.
Well, what about a back brace? I mean, like my son's got like a.
Yeah, the back brace.
Well, how long? You don't want him to sleep in it, right? That's not a good idea.
It's not a bad idea, but it doesn't. It's the muscle tone issues are more relevant in the upright position.
Because then he's relying on it. He's not. He'll do it too.
Yeah, it's not really relying on it. It's just you also want them to work on tone.
Right. That's what I'm
So
saying.
if you put them in a brace all day, the brace is doing the work, not
him.
the patient. So you want to pick ideal times to brace. And generally, I tell families it's the upright hours where you're not doing anything, where you're cooking dinner and they're not specifically working with physical therapy
That's what
or anything like that, or they're at school just sitting there the brace, you know. But if they're at physical therapy or they're doing activities, then I actually want them to work on their truncal tone.
Same thing with a neck brace, right?
The neck brace, I don't generally use
Or
neck
collar.
braces.
Well, for his, he's got.
I prefer wheelchair, you know, proper wheelchair
He tries to
adjustments.
get up, and then
Uh-huh.
you know, then you'll get stuck behind that thing.
Uh-huh.
I know a child is a 24-hour child, but sometimes
Uh-huh.
you got to run off and grab this and come back. Right
It's
then.
a little easier to control neck tone because it's not such a huge muscle and the head doesn't weigh as much as the body, that we don't generally use neck braces. We try for them to, as much as possible, to do the work of holding their head.
Are you talking about a head finger collar?
Right?
Yeah, that's what I'm talking about.
It's less of a brace, it's more of a supportive.
Yeah.
Okay, it's not rigid.
Right, yeah. You
Okay.
play around.
Yeah.
A little fold to just give them
Okay,
a little.
yeah, that makes sense.
We
Well,
do
well,
a soft compressive brace called a Spio that helps, I think, a lot, especially when they're exercising, because it gives them
Yeah.
like that kind of proprioceptive.
I wouldn't do
input.
rigid bracing while they're exercising yet.
Yeah,
But
but it gives them
something
that proprioceptive input. It can kind of help them have a little bit more.
Sorry?
It gives them a little probe, you know,
Mhm.
to give them some more input so they can control.
I used a
their
life
breath.
jacket for a long time,
Oh, yeah.
and it worked out great.
Yeah.
That's the way I grew it.
No, definitely, like, if you're going to wear a brace while you're working on core and trunk, I would use something soft.
Or with a walker. That's when we mainly used it, was with his walker.
Absolutely.
Oh, it's so free.
Huh? So you-
Oh, yeah, I noticed you have your name on here. Is there a contact information that they can provide to the people?
Yeah, I think I have to. Dr. Walsh knows how to get a hold of me. I think that's how I met some of the other families already, so I'm sorry. But yeah, there's an email or I don't have it.
Do you know it off the top of your head? So we can write
Oh
it
yeah,
down?
K Myung at IU Health.
Okay, hold
So
on.
it's my first initial MYUNG at iuhealth.org.
Thank you. Coming a little fast.
It's K, I was gonna get my name up there, KMYUNG. I don't have it up there, at iuhealth.org.
And would you be willing to accept email questions from families?
Oh, absolutely,
Okay.
absolutely.
Appreciate that.
And I can also help get them, close to who I know can handle, I think that's, because traveling is a big deal. And so, and like I said, and I told this to Nicholas's family, like, if everything goes great, it doesn't matter how far you live from your surgeon. But if things start, post-operatively, it's important at the very least that that surgeon have a relationship with someone close to you that can handle the complication too. And so, and that's a hard person to find, but I can, but I do know a lot of pediatric spine surgeons from someone in every state.